This is Roger Green, host of the Surfing the NASH Tsunami podcast. Today, we are offering 5 conversations from episode 27, our preview of key sessions and abstracts at next week's EASL Congress 2023, plus a 6th separate conversation with Arun Sanyal and David Kleiner on the benefits of AI-assisted histopathology in anticipation of a major prospective study on the topic. This conversation, which is sponsored by HistoIndex, explores the challenges in using ordinal manual histopathology in NASH clinical trials and how AI assistance might ameliorate or minimize these challenges. The purpose of the episode is to set the background for an episode later this year when a major clinical trial looking into these issues is released. The conversation starts with an important and telling digression. I asked David Kleiner, senior researcher at the National Cancer Institute and chief pathologist of the NASH CRN, how working on NASH compares to earlier diseases like hepatitis C. David explains that disease and drug-related effects are far more complex in NASH than hepatitis, because hepatitis only looks at fibrosis, but NASH adds steatosis and ballooning, and also because hepatitis is a far more stable disease. You eradicate the virus, the disease comes down, whereas in NASH you see fluctuations. Arun Sanyal notes that AI has 3 benefits. It can stabilize and standardize reads when the sample is good. It can provide information about the history of disease that a one-time manual read cannot, and allows the researcher to, as Arun puts it, layer in molecular and other tools to drive a far deeper understanding of underlying pathology. From here, the conversation dives deeper into the benefits of AI assistance in the drug dimension, including the benefits we discussed already and the value of improving measurement by creating continuous variable scoring, looking on multiple dimensions to determine what matters most, and generally developing a richer, more nuanced understanding of liver health and disease. Listen to this superb conversation to improve the nuancing of your own understanding of this issue and appreciating the upcoming trial Arun and David are previewing at the end of the conversation. This is the deepest dive our podcast has ever taken into AI. I want to thank David, Arun, and Yuan for the clarity of their statements and explanations, and I want to thank HistoIndex for giving me the opportunity to learn about something this vital. I think it's a great investment of your time. So just sit back, listen, learn, enjoy, and when you're done, join the dialogue on our LinkedIn discussion group. So now we're back for today's extra-sode. As promised, Jorn has stuck around with us, and the others have left and have been replaced by 2 fantastically esteemed and renowned colleagues. Dr. Arun Sanyal, who's been with us before, in fact, was part of what I think Arun was one of our 3 or 4 most highly rated episodes ever, or highly listened to episodes ever. How are you doing today?
Arun Sanyal.
Hey, Roger. It's great to be with you guys, and looking forward to a vibrant discussion about AI and pathology.
As are we all, and thank you, Arun. And then our other guest, who's not been on the podcast before, but David, I can't remember how many times I've seen you present. It's just the first time we've ever shared one of these things, is David Kleiner, who is a scientist at the National Cancer Institute. I guess senior research physician is the title. And David, do us a favor, just take a minute and tell our audience, anyone who might not have heard you before, if such a thing exists, a little bit about your background and how you came to be doing what you're doing today.
David Kleiner.
Well, I've been at the National Cancer Institute for about 35 years now. Did my residency here and had an interest in liver disease even before I arrived here, even as a medical student. And so when the opportunities arose to work with the liver disease section here, I grabbed them. And most of my work has been in chronic liver disease. So first with viral hepatitis and primary biliary cholangitis, and more recently with fatty liver disease and drug-induced liver injury. And most of that work has been either in the context of natural history or clinical trials of some sort or another in all of these things. So I guess my expertise is in the evaluation of liver biopsies for the use in databases and clinical trial situations. I've also done some work in liver cancer, but not nearly as much as in chronic liver disease.
David, that's fantastic and really helpful. And I'm going to ask a completely digressive question, which just popped into my head as I listened to you, which is, how is doing this work in NASH and DILI different than it is in the things that you worked on before? Is there a difference, or is it just kind of same thing, different disease?
Yes and no. Chronic viral hepatitis is actually a very simple disease histologically. It's mainly inflammation and fibrosis and the quantification of those 2 things. Whereas NASH adds in other features that are important, like steatosis and ballooning. So it's a more multidimensional kind of disease, and drug-induced liver injury is all over. So it incorporates vascular injury and biliary injury. And so the system that I developed for evaluating those cases cases is much more complex. I think one of the nice things about studying viral hepatitis C to begin with was the fact that it is a very stable disease. So from one biopsy, if you haven't treated the patient in between, from one biopsy to the next, the inflammation stays about the same, but the fibrosis will gradually increase. So it's a very well-behaved system, unlike NASH, which tends to go in and out of disease activity, and you may even see fibrosis regression without actually treating the patient. So
that's actually a great jumping off point for the rest of this conversation. Sometimes you ask a question, you get exactly the answer you didn't even think you'd be lucky enough to get. So what we're going to be talking about today is previewing, if you will, a study that's currently ongoing that I'm hoping will be back in several months after data has been published to talk about the results of. But the challenge really is to take a look at how and the degree to which AI-assisted pathology or interpretation can remedy or ameliorate some of the challenges that we see with kind of traditional ordinal histopathology. And where I think I'd like to start, David, is exactly where you were, and maybe even for you to start, which is today, people point to two sets of challenges around the technology and challenges around reader reliability, both of them having to do with the ability to capture complexity. So if you want to take one of those and dive in on where you see the challenges being today, I'll then ask Arun to handle the other one, and Jorn will ask questions as we go along.
So they are tied together. The technical aspects of reading liver biopsies are tied up in, what happens to the liver biopsy before I even get it. So how big is it? How good was the staining? How good was the sectioning? And when you go to AI, you add another layer on top of that, which is the digital scanning of the slide, which, is subject to its own potential pitfalls that can be addressed. The bugaboo, if you will, of this space has been reader reliability. And there have been obviously lots of studies on reader reliability, some good, some not so good. And I think just to draw the bottom line is that good reliability is achievable, but that doesn't seem to be the norm. And so for a number of clinical trials, for whatever reason, different pathologists were reading things differently, and that increases the noise of reading. And when you have a situation where the distinction between the before and the after is not great. So just to jump back to the viral hepatitis example, when you treat somebody with an effective antiviral, we don't use histology necessarily to measure the response, but in situations where you did and you chased the virus out of the patient with medication, the activity really goes to very low. The inflammation basically goes away. And that has not been typical in at least the clinical trials that I have seen. If the treatments over the period of time that people were doing these clinical trials really zeroed out the activity, you wouldn't need a scoring system. You could just compare the biopsies next to each other and there would be a dramatic difference. But that has not been the case for one reason or another. And so when we're trying to figure out whether a drug is effective or not, we need measuring tools which are maybe not so noisy as a human is.
So Arun, I noticed you nodding at the end and then furrowing your brow a bit at one point. What about David's comment struck you as being dead on, and would you like to elaborate on or shift a couple of degrees to the left or right, as it were?
Yeah, first of all, I do not have the temerity to disagree with David. First of all, he's the NASH CRN's chief pathologist, so I can't disagree with him too much because he controls the pathology output from there. No, jokes apart. I think David is right on. As a clinician, we trained in an era where reading histology was part of our clinical training. What we learned the hard way is that there are three sets of things that impact the quality of the histology readout. Things that you do before the sample even arrives in the laboratory, the size of the needle, the gauge of the needle, the kind of quality of the core that you obtain, whether it's fragmented or not, and how long the sample sits on a piece of gauze before somebody decides to put it in formaldehyde and ship it to the lab. All of those kind of things matter. Number two, in the lab, how they process the sample, embed it, and then how the sectioning is done, whether you're getting sections from the juicy middle part of the section or you're just getting the top layer or the bottom layer. All of those things matter. And then sometimes you have a little nick on the blade, which leaves a deep furrow. You have the Grand Canyon going through the middle of the biopsy. That makes it a little more challenging. So all of those things. And then there is the pathologist who then has to interpret all of this, sometimes without any clinical data. We are looking for specificity where many of the histologic findings are not necessarily specific to a given disease state. So all of those are sort of a priori challenges. And I think where the role of AI comes in is one is to, AI cannot fix, if you put really scraps of tissue on the slide, AI cannot fix that. But assuming you have a reasonable piece of tissue on the slide, then the AI can help the pathologist gain confidence and reduce some of the variability in the histology reading. That's one application. The second application is to learn new things about the histologic evolution of the disease, which is not apparent with conventional staining. And number three is to be able to layer in molecular and other tools to really understand what's happening at a molecular basis, so that eventually one day we can theoretically at least match what is going on biologically in the patient to the right drug target, as opposed to throwing the drugs at a bunch of patients hoping for some of them this will be effective.
Jörn Schattenberg.
Something that resounded with me was David commented on the changes in Hep C and how they're not being as prominent in NASH compared to that. And I think, from the learning the field has taken, it was a natural decision to look at changes in liver histology and be able to decide on the outcome of the patient. But it took us some time to understand, from my perspective, that hasn't been as long in the field as Arun or David. That's one of the big learnings, and that we need augmentations of the reading, either by adding blood-based biomarkers, imaging, or, even augmenting the liver histology to actually link this to an outcome. And I think Arun also mentioned something here where he said that there is additional information in the biopsy that might not be described by the NASH CRN, the NAS score, which it wasn't designed for. And I think at that basis, AI will help us to figure out some of the details in more depth.
So you are in the last one of these that we did, that was sponsored by HistoIndex, was the one that you chaired a few months ago, where we talked about second generation harmonic convergence and the ability to compare different drugs to see where in the liver they were having effect. I assume that's the kind of thing that we're talking about when we say learning things we couldn't learn from biopsy.
Well, I'm very intrigued by the type of fibrosis patterns, and David can speak to that in more length. And I think Arun also has seen a lot of that data in the trials he runs. But, fibrosis doesn't always just go away. It starts to kind of dissolve at one point, and I think that's important where you look. And maybe, David, tell me about it, but the current fibrosis staging systems might not be the right ones to study regeneration as much. Is that correct?
So the challenge with fibrosis regression is that it doesn't always look the same as what you would get if the disease progressed from beginning to end in a monotonic way, right? Which is what Hep C does. I hate to keep coming back to that, but it is a really well-behaved system. So what you see in fibrosis regression is, yes, you get two things. You get the collagen becomes more compact, it's basically like sort of an open basket weave going to a very collapsed kind of compact layer. So that's one thing that happens. The fibrosis gets thinner. So what we see as fibrosis under the microscope may be, say, as wide as a hepatocyte, which doesn't necessarily mean anything to your office or your audience, but it's about 50 microns wide, so 1/20th of a millimeter. And it gradually narrows, or it becomes discontinuous. So you get little chunks of collagen that are just sort of sitting there in the middle of the parenchyma. And the scoring systems really don't deal with that very well when you get these disconnected pieces. And so it becomes a challenge just to sort of assign those semi-quantitative numbers to the case. Even so, as a pathologist, I can say, gee, this looks like fibrosis regression. It's not captured by a numbered system. It's just a qualitative observation. But I see that on patients who are just within their natural history. As the activity waxes and wanes, the fibrosis can regress. And I think that kind of throws a wrench into some of the systems sometimes. What we need to do with the AI is learn how to describe those things and measure them in a way that is clinically meaningful, which I think there's still a lot of work to do on that, but it's at least doable.
So first of all, before I turn to Arun, for whom I have a question, I want to note to the audience that every time David mentions the word hepatitis, visualize a thought bubble going up above his head that says, "Life used to be so simple," because that would capture the look on his face in the moments that he says that. But it's not so simple anymore. So Arun, you brought AI into the conversation in terms of a couple of things that it can do. Could you elaborate a little bit on where you think its greatest benefits are, first of all, in drug development, and then second, in just basic hepatic knowledge?
Well, I think in drug development, probably where the low-hanging fruit is how AI can assist the pathologist. Remember, I'm using the word assist, not replace, but assist the pathologist in having greater confidence in ascertaining the degree of activity and the fibrosis stage. Between the two, there's a tremendous amount of emphasis on fibrosis because fibrosis is what determines prognosis. And so changes in fibrosis are considered highly relevant in terms of translation into what is considered clinically meaningful from a prognostic and a clinical outcomes perspective. And so when the histologic readout for fibrosis is noisy, then you need larger sample sizes and you need bigger effect sizes. So the two consequences of the current background subjective variability in the readouts is that because of this background noise, you need larger sample sizes, and which means bigger studies, and you need bigger effect sizes. So drugs that are not massively effective in wiping out, either activity or fibrosis and are closer to the upper bound of the noise, they have a harder time separating themselves from the noise. Therein lies the challenge. So you could argue if only we had drugs that had more effects on the activity or more effects on the fibrosis, this would not be an issue. But conversely, you could also argue that if you improve the fidelity with which you get a histologic readout, then we would be able to capture things with greater sensitivity. The other point over here is that the fibrosis scoring system is currently an ordinal scoring system. So you go from 1 to 2 to 3 to 4, and the data on prognosis is linked to this ordinal system. But in our early stage studies, where we're trying to figure out whether there's enough action to move forward and do a very large study, you asked about drug development, we may want to capture changes in fibrosis, at a more granular and with greater sensitivity. So you have to increase the gain on the readout of the changes in fibrosis. And I think that is where AI tools can really help the pathologist figure out if things are moving or shifting in the right direction, with the caveat that I think both Jorn and David pointed out, that as we published with the tropifexor study, that while fibrosis progresses from stage 1 to 2 to 3 to 4, with drug therapy, especially drug therapy that is targeting the hepatocytes, one of the first places where the collagen cleans up is actually that perihepatic, in the sinusoids, the fibrosis. And so it may take much longer for the actual septa to thin out and break up and other things. So greater certainty in readout of the pathology and being able to identify changes in activity and fibrosis with greater sensitivity. Those are sort of the low-hanging fruit, in my view.
Okay, so one more question to you and then to Jorn. You mentioned ordinal scoring, and then you mentioned the need to be more sensitive. Is ordinal scoring also part of the problem here? Or is that something we can overcome if we simply had more consistent reads or clearer definition from drugs?
Well, I think we have to develop and validate a more, a continuous scale for evaluating the fibrosis. So remember that fibrosis is changing on multiple dimensions. So one is the fibrosis in the sinusoid. One is and within the lobule, there's fibrosis around the central vein. There's fibrosis in the periportal area, and there's fibrosis in the middle. Then you have portal fibrosis, then you have septal fibrosis. So where one of the things we promoted and pushed forward through some of these clinical trial-related studies we did is to look at fibrosis along 5 different axes and summarize it in the form of a radar plot, where you can actually see, in which dimension whether the fibrosis is changing and whether it's decreasing, increasing, or remaining stable along each of these different axes. So that gives you a more holistic view of how fibrosis is changing in different parts of the liver section. But I'll let David comment also on if he thinks there's value in some of these things.
I do actually. I think the huge promise of AI is to be able to measure things that are challenging for us to measure. And that's not just the basic scoring that we do, but a lot of other things which may turn out to be very important. And obviously there's a lot of work to be done to show that a particular observation is important. But, Arun touched on fibrosis. You could make the same kind of analogy with all of the other features in the biopsy, where the inflammation is in the portal areas or in the parenchyma, how much there is, how many different foci, how many lymphocytes are actually present in these different areas. With steatosis, you could look at numbers of vacuoles, the size of each individual vacuole, the range of vacuole sizes across the biopsy. I mean, you can really get quite granular with a good AI system. The issue is right now, we don't really know what of those features is important. And that includes the fibrosis. We see these changes, and what we need to do now in clinical trials and other studies is to try and understand what the meaning is of these things. Because if it turns out that the disappearance of perisinusoidal fibrosis, and if that's the first thing that goes away when you treat somebody, if that's a really important clue and it's clinically meaningful, that's a really important piece of information that everybody can use. And we don't have to worry about the more established structural collagen if what we want to do is find out which drug is showing promise early on. But we need to do those studies, and we need to show that that's a meaningful endpoint, because right now all of the studies are based on these scores that humans do, and so everybody is trying to replicate those first.
I think to add on to that, and Arun mentioned the TROPIFEXR study, which has a detailed histopathological AI-supported assessment, is actually, it might be more complex that not every MOA does resolve fibrosis in the same way. Now, I'm just saying this as a hypothesis, but we need more data, and for that reason, I think we need to run these technologies in the trials to also understand it and form the field and know where we're moving. And David said to link this to a clinically meaningful change. It will need some time, but we have the opportunity now, I think.
So moving forward to the third part of the discussion. So Arun, with all that as a background, the study that we're previewing, because we have no data and we're not talking about results, just kind of why and what's in it. What is the goal of the exercise specifically in the context of what we've been talking about so far?
I think the goal of the study is primarily to validate in as rigorous a manner as possible the ability, and this is really focused on fibrosis. It could be, you could design a study to look at other aspects as well, but the focus of this particular study is primarily fibrosis for the reasons I alluded to earlier. And to be able to see whether provision of either second harmonic generated images, so just the image, not any scores or anything, just the image, along with the conventional H&E and serious red staining, whether provision of that second harmonic generated image gives the pathologist what he needs to be more sure of, what they're looking at. Number two, in addition to these, if you actually provide specific scores, like the quantitative fibrosis score, etc., or the mean septal width and things like that whether that actually gives the pathologist even more confidence. And of course, it's not just a matter of confidence, it's also a matter of trying to understand whether you can reduce the variance from one pathologist to the other in terms of being able to identify more tightly what a given stage of fibrosis. And lastly, to try and start getting an understanding of, three pathologists could all agree with each other and all three could be wrong. So in the end, we have to also understand how does this relate to ground truth. And I think this study tries to do this to the extent possible, knowing that the only way you can get ground truth is to really take the liver out and section it, 4 microns at a time, which is obviously not feasible. So to the best extent possible to get a handle on the ground truth, but also really to answer whether just provision of some additional, it's like adding another stain. The second harmonic is like, you went from Masson trichrome to serious red, now you got a second harmonic stain, and does that help you or not? Really to answer that question with or without additional actually numerically derived scores, numerical scores to go with it.
David, anything you want to add to that before we dive into exactly what the study specs and parameters are?
So, not to focus on any particular tool because I'm not supposed to do that, but one of the first advantages of using these AI tools is their ability to present a consistent interface to the pathologist, and one that can be evaluated at relatively low magnification. The easier it is to see the changes at, across the whole biopsy at low magnification, the more consistent your scoring will be, your more consistent recognition of features. So whether you're highlighting fibrosis using 2D harmonic generation or some other methodology, or you're highlighting steatosis or ballooning or something else using other methodologies, if you can present that consistent interface to the pathologist, I think just the act of doing that will get you better agreement. And then, beyond that, if the interface is also offering, well, this is where this biopsy falls on the range of 0 to 4, that also is very helpful, because especially when you're not, some things are very clear. better, and some things are not. And so when you're not certain about something, then having a numerical estimate for whatever you're trying to score is helpful.
Okay, that makes sense. Although the only thing I'm wondering is if there's any magic to 0 to 4 in the scheme of things.
So humans are good at differentiating multiple categories up to about 7. And you see that, so there is one staging system, the Ishak staging system, which is 0 to 6, and so 7 categories, and that's reasonably reproducible. But to get any finer than that is difficult. And so we picked 4 just because most staging systems are 0 to 4, and the lines that we were drawing between different stages are comparable to other staging systems that people were familiar with. So we hope to benefit from that. And that was the other scales that we came up with were also ones where we thought we had a group of pathologists for the NASH CRN, and we said, what do you think you can do? How fine a distinction can you make? So, for ballooning, it came out 0, 1, 2, and for other things, it was 0 to 3. So depending on how you look at things, you can get finer distinctions than that. In the just using, again, human observations, we've been able to extend the ballooning scale to 4, 0 to 4, with specific criteria, and that's also reasonably reproducible in our hands.
So, Arun, do us a favor, in the few minutes we've got left, start by walking us through what this design is and how it is designed to address the various issues we've been talking about in this podcast.
Yeah, so the design really involves, first of all, a selection of both experienced and relatively early career pathologists. That gives us an opportunity to look whether the experience of the pathologist makes a difference. Are there based on how much experience do you have, does it make any difference whether AI is more useful in one group versus another? Number 2, we go through a couple of randomizations where a group of biopsy slides that actually cover the spectrum of NASH fibrosis, so from 0 to 4, they are in random order reviewed by the pathologist using the conventional approach versus having the second harmonic generated image available to them. And this is done in a random order so that every pathologist reviews every biopsy, but none of them review it in the same order. Secondly, in order to reduce a potential bias of pathologists talking to each other about biopsies, etc., or knowing what a more senior pathologist thought it was, the pathologists are actually blinded to each other. So no pathologist participating in the study actually knows who the other pathologists are. So they have been all kept completely individually separated and firewalled, if you will. And then after the first set of readout, then there is a washout period, and then the thing is done all over again. And with the addition of the fibrosis score, the Q fibrosis score in addition to the fibrosis images. And then it is sort of reanalyzed again. And so basically what this does is it allows us to be able to look at how each person scored each biopsy themselves with and without second harmonic generated images in a very random order, and then pairwise comparisons of the pathologists, and then the overall degree of variance with an individual and across the group as a whole, and also to be able to see whether incrementally addition of these numerical scores provides value beyond looking at the image. We also ask the pathologists after each reading to tell us, did they find it useful or not? And then, of course, we can correlate the overall performance with the pathologist's own reading of their own performance and confidence to see whether things did improve or not. So I think that's sort of at a high level how the study is broadly structured. David, did you want to add anything to that?
No, I think you covered it pretty well. The blinding of everybody to everything, multiple observations over a period of time, with and without the assistance of the AI tool. I mean, that's the way that, and with this little survey afterwards, that's the way that this study was designed. And so the idea is that hopefully the AI tool makes things better. What I would emphasize is since none of these pathologists know each other, or at least didn't talk to each other about anything, they didn't even establish their own internal guidelines, right? So there are all kinds of situations that come up when you're looking at fibrosis, and it's important to know, if you're trying to be reproducible with each other, to know how somebody else might interpret a particular situation that comes up. We talk about these stages as if they were very simple things, but every single biopsy, you have to make decisions about what you see, and having clear criteria or clear understanding of what everyone is agreeing on when you hit these complicated situations will also increase reproducibility. So they didn't have that. So they started from nothing. So so if you see better reproducibility, then that's great, because that's the way most clinical trials are designed, is the pathologists don't talk to each other beforehand.
Oh, no, not really. I think this is a very important aspect and a thoroughly thought about scientific, approach in trying to decipher what this type of histological reading, how it can be refined. So no, again, congratulations both, and looking forward to trial results, I guess.
I completely agree. A research scientist I know once told me that anytime you can get the words elegant and rigorous into the same description, you've done something special. And I think both those apply here. So the only other question I've got is, Arun, you made a very, very tantalizing comment about ground truth. Is it reasonable to expect or reasonable to hope that something about ground truth will emerge from this discussion? And if so, what form do you think that'll take?
Well, I think the ground truth eventually will require validation, not only, as we develop more longitudinal studies, we will be able to see whether these more short-term changes translate into more disease or less disease in the long term. That's one way to sort of get to the ground truth. Another way is to look at a lot of NITs and see, the concordance. If 5 different NITs also agree with the direction of the reading of the pathologist, that's another way to sort of think about ground truth. And lastly, of course, ground truth also has to look at collagen quantification, some of these other type of more quantitative tools that we can see if the pathologist all said the fibrosis was worsening and the proportionate area increased. That's another sort of way of sort of getting that, yes, things were getting worse. Or conversely, things are getting better. So I think there are different ways, because this comes up all the time when we're talking about validation of some of these AI tools, particularly with regulatory agencies. But it is not easy to establish ground truth when the liver is still sitting inside the patient and none of the NITs have been validated either to represent the ground truth. So the best, it's like infinity. You can approach infinity, you cannot actually be at infinity. So I think ground truth is an aspirational goal. But through all of these, I think this will certainly generate, I think the results of the study will generate a very robust conversation and hopefully some innovation about some best practices in trying to establish the ground truths. Because in the end, there is a huge impact when we make a false assumption and either kill a drug that actually is potentially beneficial, or we bring a drug forward into phase 3 and then fail miserably. And there are probably instances certainly of drugs being moved into phase 3 and failing in phase 3 in the NASH space that we all remember. So the closer we can get to this important question, the better it'll be for the field and for all our patients.
Yeah, and to just elaborate on what you said, given my background as a forecaster, quick, correct kills in development are the single most cost-effective thing a manufacturer can do. So amen to that. Look, this has been a fantastic conversation. I'm excited to see the results of the study. Jorn, David, Arun, thanks for a fantastic discussion, and I certainly emerge feeling a lot better educated. I think our listeners will as well. And look forward to seeing you guys back in November when we can talk about the actual, or at some point in the future, we can actually talk about the results of this thing. Everyone have a good afternoon.
Thank you. Great seeing you.
Thank you. Bye, guys.
Bye-bye now.
Today's episode has been sponsored by HistoIndex, the first global company to provide stain-free, fully automated imaging solutions for visualizing and quantifying morphological and architectural features of fibrosis.
HistoIndex couples breakthrough biophotonic technology with an AI-powered digital pathology system to provide consistent, high-throughput imaging in liver disease and cancer.
The platform benefits clinical research and speeds development of drugs and diagnostics.
For more information, visit www.histoindex.com.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingnash.com. We hope to be back early or middle next week with a preview of the ADA convention in San Diego. We will clearly be back next weekend with a bunch of coverage at the EASL event itself. So until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.